Good afternoon, everyone. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, I would like to welcome you to our monthly webinar. Today's topic is oral manifestations of systemic disease and conditions, presented by Dr. Paras Patel. Dr. Paras B. Patel is a board-certified oral and maxillofacial pathologist who obtained his dental degree from Howard University College of Dentistry in 2011. Dr. Patel went on to practice general dentistry for a couple of years in the Lubbock area, working on a mobile dental unit with the FQHC. In 2014, he began his residency in oral and maxillofacial pathology at Texas A&M University College of Dentistry. Upon completion of his residency, Dr. Patel took a position at the College of Dentistry and is currently a full-time faculty member in the Department of Diagnostic Sciences. He maintains a clinical practice actively seeing patients who suffer from various oral diseases in the Stomatology Center at the College of Dentistry and is an active surgical pathologist in a busy biopsy service. Dr. Patel's previous work experience and curiosity have shaped his approach to diagnosis and management of disease. So it is with extreme pleasure that I turn the controls over now to Dr. Patel.
Thank you, Beth. Thanks again to everybody for this opportunity. Thank you guys for attending. Beth started off by saying if we do go over, it's because last time we went definitely over. So I'll try to be cognizant of everybody's time and hopefully finish within the time frame of an hour today. I have a tendency to lecture pretty casually, and it seems like it's a fairly small group, so please feel free to unmute yourself and participate if you do have questions or comments or stories of similar situations that you've had in practice. I think you're more than welcome to unmute and participate or raise your hand. Or again, we'll keep an eye on the chat box so we can kind of go through and answer questions as they come. I'm going to go ahead and get started. I'm going to share my screen here. So today we're going to talk about the oral manifestations of systemic diseases. And this is a huge topic, and you could talk about this for probably days, it would be my guess. People often don't realize that the oral cavity, it really is a window to the overall body, and it, any of these systemic diseases that not just we're going to discuss, but many systemic diseases can have manifestations that will present in the oral cavity or the head and neck region. And you could be in a position as part of the healthcare team, particularly those focused on oral healthcare, to find some of these manifestations prior to the patient's diagnosis of their underlying disease and play a pretty much an instrumental role in making sure that they get properly diagnosed. So I'm going to move through the slides here. Let's get this pointer out. So what are we going to cover today? And these topics kind of go all over the place. We have vitamin mineral deficiencies, some endocrinopathies, thyroid dysfunction, adrenal dysfunction, diabetes, mellitus is in there as well, inflammatory bowel disease, burning mouth syndrome, xerostomia, a dry mouth. It doesn't seem like there's really a link to these. And the way we're going to cover this is going to be a little bit of a clinical case-based approach. So I've decided to change this lecture style around a little bit and use clinical scenarios to then act as a jumping point to discuss a wide range of systemic diseases that could potentially have the same clinical manifestation. And so we'll talk about the underlying systemic diseases that could result in A, and not only that, but when we go into those systemic diseases, we'll talk about some of the other manifestations that you can see as a result of those diseases. So again, it is the overall body that we're going to look at, but specifically what can present in the oral cavity in regards to some of the underlying diseases and conditions. So we have to start with the basics. This is Sir William Osler, one of the founding fathers of housemanship or clinical residency in medicine, and just was a fantastic clinician, and he had this quote, and I've kind of paraphrased it here, but listen to your patient. He or she is telling you their diagnosis. And that's really critical. And it's not always active listening, but it's looking and evaluating at the clues that the patient has provided to you to come up with why they have a certain clinical presentation. And this starts with the questionnaire. A lot of times the clinicians will get the questionnaire, or part of the healthcare team will get the questionnaire prior to seeing the patient. It is really critically important to evaluate that questionnaire with great detail, paying attention to everything the patient has gone through. And not only that, I have a tendency to discuss the questionnaire with the patient. And as you walk through the questionnaire, more often than not, I've found that the patients will remember something through the course of the discussion that they forgot to put on the questionnaire. And majority of the time, it may be something insignificant, but in some cases, that little piece that was left out could be significant in regards to patient management. One of the classic examples of that is patients who are taking certain infusion medications to combat osteoporosis. They may not be getting infusions regularly, and because of that, they don't put it down on their medication list. Okay, but some of these anti-resorptive therapies, and I classify them as anti-resorptive therapies, they could have significant effects on the way you're going to do surgery and the way you're going to manage these patients. So it runs a gamut in regards to the overall things that need to be discussed with your patient. Vital signs, critically important that you're taking vitals every time the patient comes in, which is typically routine practice at this point. And not just that, paying attention to the vital signs. Patients will come in and may have a touch of white coat syndrome. It's important to recognize that, but also ask them if they're hypertensive. What are their regular readings like? Do they keep a log? If they don't, ask them, hey, for a week, why don't you just keep track of your blood pressure if you have an at-home monitor, and let's see what it looks like. And then if you're looking at it and you realize that it is not well controlled, that's a point of discussion with the physician. Okay. And then our clinical exam. This starts with the patient walking in, their gait, evaluating anything on exposed skin, evaluating them for any other signs of diseases, local or systemic. And again, goes to the importance of a head and neck exam as well. All right, just a little kind of disclosure about the image use and references that I have. All the images that I've used here are either from texts, because textbook examples are the best, or from personal cases and online sources which have been appropriately quoted or referenced. The patients that I'm describing and the characters that I use are purely fictional, and they're being used for educational purposes. And I say that as we meet our first patient. Okay, so our first patient is Mr. Jason Bourne, good-looking gentleman to me, and so he seems pretty healthy. And as we discuss with him what's been bothering him, he says that he has multiple ulcers in his mouth. Okay, he calls them canker sores, right? He said, I get these canker sores in my mouth and they hurt, and he has one here in the left buccal mucosa near the commissure. We have another one here in the floor of the mouth. And then he has another one here as it approaches the posterior aspect of the soft palate near the tonsillar region of the oropharynx. So what is this? What are we dealing with? Well, we're dealing with multiple ulcers, right? So the questions we need to ask him are, has this happened before? And if so, how often? And in asking him that, he says that this happens pretty much cyclically, and they come up and then, they either hurt and he may be using something over the counter for pain, or he may have had a prior prescription from another physician. A magic mouthwash is common. Sometimes people try acyclovir or other anti-herpes viral medications when they see an ulcer. It's important for us to address that whenever we see ulcers like this, on movable mucosa. It's not the typical pattern that we see with herpetic lesions. Okay, the herpetic lesions that we see that are recurrent are typically going to be in immunocompetent patients on bound down mucosa. That means bound down to the areas of the bone and the periosteum. And they're typically punctate ulcerations, which can have a tendency to coalesce and form larger ulcers. Okay, and that again is with recurrent HSV infections. So these are isolated, large, pretty well-defined ulcerations with some erythema, and all located on the movable mucosa. And that's one big way to separate recurrent HSV infections versus aphthous-like ulcers. Okay, so we're dealing with recurrent aphthous ulcerations or aphthous-like ulcerations. So looking at systemic diseases that can cause ulcerations, there are a handful of diseases and conditions that can result to the breakdown of your epithelium. Okay, one of the most important ones being vitamin and mineral deficiency, which is easily overlooked. And this could be a primary vitamin or mineral deficiency, meaning that the patient is not getting enough of a dietary source of this, or they're not being supplemented if there is some gap in their diet, right? I see this commonly in patients who have special needs. There's a handful of patients that may not like to eat specific foods because of texture. I've seen a handful of vitamin deficiencies in young autistic children that have a tendency to eat certain types of food. You can see this in elderly, anybody that needs or requires the care of a healthcare provider or pretty much an in-home healthcare or home caretaker. Sorry. So you can see this in a wide range of things in regards to dietary vitamin and mineral deficiencies. You can also see this secondarily in inflammatory bowel diseases. Ulcerative colitis is a disease process, typically affects the large colon. The large intestine. And in those cases, there may be a lack of proper absorption of minerals and nutrients. In Crohn's, we see this more frequently because it affects the small bowel. And again, Crohn's is one of those disease processes that can affect pretty much from top to bottom. And so you can have effects in the anal region as well as in the oral cavity that can be clinically manifested as a function of this underlying disease process. And in Crohn's disease, you can also have this vitamin mineral deficiency develop as a function of the inflammation in the gut, which doesn't allow for proper absorption of nutrients. Okay, Behcet syndrome is a disease process that we'll discuss that has a specific inflammatory. It is a specific inflammatory condition in which you develop a vasculitis. Celiac disease and gluten intolerance has some genetic components to it that can result in oral ulcerations. Immune compromise states, whether it be through HIV and AIDS or topical immunosuppression or systemic immunosuppression, more so with systemic immunosuppression for patients who have autoimmune diseases and things like that. And it could be something primarily happening, or it could be secondary to some of the hematologic abnormalities that arise in those patients. Cyclic neutropenia is another one. There's a handful of other autoinflammatory conditions that are rare. And then the last thing that's important, and it's not really a systemic disease or condition, but medications. And this is huge because there are a lot of medications that can have these idiosyncratic reactions that result in ulcerations forming and affecting the oral mucosa, amongst other sites. So we'll start by talking about vitamin and mineral deficiency. And I'm not going to touch on everything in that list, but we're going to touch on the ones that we may find more frequently in our practice. So what vitamins are we looking at? That's a big way to start. And vitamin B1, 2, 6, 12, and folate are really big in regards to resulting in an ulceration if they're deficient in those vitamins, okay? A lot of these vitamins can be found in leafy greens, meats, nuts, legumes, things like that. And so these vitamins, the B vitamins, have a tendency to play a role in the maintenance of your epithelial integrity, okay? When you're deficient in these things, you have a tendency to have a little more breakdown, and in some cases, some degree of atrophy of the epithelium, which makes it more susceptible through chronic irritation that may not be major irritation, just a minor trauma could cause a breakdown of that epithelium. Minerals like zinc and iron. Yeah, minerals like zinc and iron also play a role in epithelial integrity, and so they can result in the same process. and result in ulcerations that can affect the oral cavity. So the causes of this could be, again, malnutrition, dietary sources, could be secondary to inflammatory bowel diseases, as I mentioned, or autoimmune conditions like pernicious anemia. Okay, pernicious anemia is a disease process in which some of the cells in your gut that are responsible for making intrinsic factor, which is necessary to absorb B12, are damaged. And because of that damage, you don't make that factor that allows for adequate absorption of B12, and you become deficient in it, and you develop what's the classic megaloblastic anemia in those cases. Ooh. All right. So one of the other things we can see in patients who may be deficient in vitamins and minerals is this sort of erythematous appearance. And most frequently and most predominantly, we'll see the effect on the tongue. So they may have a generalized erythema, but on the tongue, you'll start to see a balding appearance. You won't have the normal papillary appearance of the tongue. And so it'll look a little more bald, sometimes a little more beefy red. On top of that, you can have patients who will develop angular cheilitis. You can see this here at the corners of the mouth, oftentimes associated with candidal organisms, but you have to understand that we can see this with patients who are iron and zinc deficient as well. So any of these things, along with symptoms of paresthesia, sometimes they can have tingling in their digits, their toes. And if you have some of these signs and symptoms along with burning, which can also be seen in vitamin deficiency and mineral deficiency, it's something to look at or determine whether that could be the cause of this underlying oral manifestation. Okay. So inflammatory bowel diseases, ulcerative colitis and Crohn's disease, anywhere from top to bottom for Crohn's, like I mentioned, and ulcerative colitis is typically large bowel disease. UC, or ulcerative colitis, has bimodal peaks in 15 to 30, and then a little bit older in the 6th through 8th decades, and relatively equal distributions in regards to affecting males and females. Crohn's, on the other hand, oftentimes we see this more in younger populations. It does have a slight female predominance, but it is roughly equal in regards to its effect and gender selection. So what kind of other manifestations can we see on top of the fact that ulcerations can be seen with inflammatory bowel disease? Well, with inflammatory bowel disease, we can get these really interesting snail track-like ulcers with surrounding erythema that are most often painful in patients who have either ulcerative colitis or Crohn's. And that disease process is called piostomatitis vegetans. And sometimes that is a unique presentation that if you see this, it should make you consider ulcerative colitis or Crohn's disease to that extent. Crohn's disease can also present with this cobblestone-like appearance of the mucosa, and that's a direct involvement. The type of inflammation we see with Crohn's in the gut is granulomatous inflammation, and when that affects the oral mucosa, it can produce this really cobblestone appearance that can be present. And again, ulcerations. And most often the ulcerations are secondary to some degree of vitamin or mineral deficiency. Okay. This is a classic example of piostomatitis vegetans, these kind of snail track, serpiginous-like ulcerations. There's areas of erythema adjacent to it, similar to an appearance that you see with geographic tongue, but these are throughout the mouth here in this individual, and they are painful. And just for reference, this is a slug, which I think is probably just a homeless snail. And these are these snail track-like marks on our front walkway here. And you can kind of see that they have this kind of back and forth serpiginous pattern. I hope you're humoring me, that are similar to these snail track-like ulcerations that are associated with these inflammatory bowel diseases, okay? Here's another example. This is in the vestibule of an individual who had this sort of snail track pattern of this ulcer here. It was painful, and the patient was not aware of any diagnosed, or at least was not diagnosed with any underlying bowel disease. And it was a biopsy of this area as well as this evaluation that actually led to that patient's diagnosis. Okay. Here's another area. It's just a linear ulceration that we're seeing at the vestibule, and that has been commonly described in these conditions. And it's this linear ulceration just at the depth of the vestibule. And this is unfortunately a photo that's a little out of focus, but you can probably make it out a little better here. And this was biopsied and actually showed evidence of granulomatous inflammation and led to the diagnosis of the patient's underlying Crohn's disease. This is an interesting case that I had in my last year of residency. A young Asian female, she was referred to me for what was suspected to be an allergic reaction to her orthodontic brackets. And she came in, there's clearly some swelling of the upper and lower lip that's visible extraorally. Intraorally, the first photos we have are her with the brackets, and you can see these areas here, which really do approximate the brackets that are placed on the teeth. So I thought that was a very good thought by the clinician. So they took the brackets off. Okay. The patient presented to me about 3 months after the brackets had been taken off. And you see there's this little area, kind of a little fibrous bump in here, and relatively nonspecific and insignificant. And you look in her oral mucosa, and she has these folds here, and you can kind of make out the folds a little more posteriorly. She still has the swelling associated with the areas of the brackets, but not as pronounced. So this was the areas of the brackets, and again, linear. But if you look away from that, in areas even higher away in the vestibule, we have just a little bit of this cobblestone-like appearance, or these undulating areas that are not consistent with a smooth mucosal surface. And so we ended up doing a biopsy on this patient. And this patient, during the first couple of appointments, we asked about underlying diseases. She said she was healthy. She came with her father the first 2 times that she had seen me. I asked about gastrointestinal disease or anything else, and she said nothing. The last time she came in for her post-operative visit, she came in with her mother. And I again brought up the possibility of, by this time we had done a biopsy and found some evidence of granulomatous inflammation. And so I brought up even more strongly that, do you really have any other gastrointestinal disease? And she said no. And her mother stopped her and said, yes, you do. And she said, and the mother looked at me and she said, she always has issues after eating or even in between eating. She always complains of cramps and all this other stuff. And I was like, is she anemic? And the mother was like, absolutely. They've been giving her iron infusions for a little over a year. And I said, have they found the cause of the anemia? And she said, no, they haven't. And they hadn't worked her up further. So as with the information I had, I called the physician and I said, this patient to me is very suspicious for having Crohn's disease. And she was sent to a gastroenterologist, and they started her on infusions and prednisone right away. She had some pretty advanced Crohn's at that point, but they were able to get it under control. So again, the oral manifestation leading to the diagnosis of the underlying systemic condition in that case. Behcet syndrome is it is classified as a vasculitides or a vasculitis. There's a slight male predominance. We see this often in the 3rd and 4th decades, so the 20s and 30s. It is associated with a specific HLA subtype, which is HLA-B51. No real cause in regards to an inciting factor in what results in this vasculitis. But as a result of this disease process, these individuals get oral ulcerations as well as ulcerations in other regions, such as the genital region. Almost all patients will have oral ulcerations prior to more widespread disease. And that is very important, because oftentimes you have patients come in and it may just be the oral ulcerations that are present. And again, as I mentioned at the beginning, we're dealing with underlying systemic diseases in this topic, or as far as this topic goes. So oftentimes you rule out local factors prior to jumping into systemic diseases. And so when they present with something like this, you're not necessarily thinking that there could be an underlying systemic condition, because there's an absence of other symptoms. But there are diseases like Behcet's that will have the oral manifestations prior to more fulminant systemic symptoms. And the criteria for this diagnosis, one, it's either minor, major, or herpetiform type aphthous type ulcers in the oral cavity. And that's a necessary criteria to make this diagnosis, plus two other findings. So anogenital ulcerations, any sort of ocular inflammation, as well as a handful of different skin lesions that can form as a result of the vasculitis and subsequent inflammatory process. Okay, so there's a handful of things that will present kind of like Behcet's in this setting with the oral ulcers, right? So moving on to HIV and AIDS, again, immunosuppression or an immune compromised state can also result in oral ulcerations. So speaking specifically about HIV and AIDS, what is AIDS? We all should know it's acquired immunodeficiency syndrome. It's caused by human immunodeficiency virus, right? HIV and HIV 1 and 2. 1 is a worldwide distribution and accounts for majority of the epidemic cases that we see. HIV 2 is in Western Africa and has a slower progression and a lower transmission rate. It's immunodeficiency because it specifically targets immune cells and it makes them incapable of responding to any sort of antigenic stimulation, right? And a syndrome is just simply any group of symptoms that consistently have a tendency to occur together. All right, so what populations are most affected? And it still remains that most often we see this in the group of men who have sex with men, but we can see this in intravenous drug users, hemophiliacs, but hemophiliacs typically prior to the 80s, and that's because in the mid 80s they started screening for HIV in the blood, and so now we don't really see this in patients who have had transfusions or multiple transfusions from blood products. Heterosexual contacts of any of the above. And again, you can see this in any population, but it's good to be cognizant about what the demographics are because that's one piece of this entire puzzle that can help you in making your definitive diagnosis or your provisional diagnosis, I should say. So the clinical stages of HIV, the acute infection is kind of like any sort of acute viral infection syndrome, okay? And they call it acute retroviral syndrome in this case, 1 to 6 weeks. And like any other primary infection, a lot of times we have some high viremia, you have generalized lymphadenopathy, fever, the other constitutional signs that you would expect to see in an infection, okay? Whether it be viral or bacterial in some cases. During the initial phase of disease, HIV infection is often overlooked because a lot of this could be chalked up as flu-like symptoms or any other illness where you're under the weather. So you don't typically jump to, hey, do we need to work this patient up for HIV during that phase? Chronic can go from months to years without treatment. Viremia typically declines during this stage. These individuals will have a persistent generalized lymphadenopathy that's more than 3 months, and it'll be in extrainguinal sites. So you can see it in the submandibular region, in the head and neck, as well as other places on the body. And this may actually suggest a progression to AIDS, that persistent lymphadenopathy. Oftentimes we'll see chronic weight loss, fever, and in some cases diarrhea. And then at the latter stages of this process, we start to see the development of opportunistic infections, as well as the other signs and symptoms that go along with AIDS itself. So how do these oral lesions develop in AIDS, right? So we can see a handful of different oral lesions as a result of HIV infection and AIDS itself, directly related to immunodeficient state, okay? So a lot of this is gonna be opportunistic or a dysregulated immune response. So similar lesions can be seen in other immunodeficient situations. So that's really critical to understand. It could be in patients who have autoimmune disease, and a lot of times it's the therapy you use for autoimmune disease that's going to help or not help, but contribute to the immunosuppression, widespread malignant disease. And then other times, like I mentioned, it is medically induced immunosuppression that you can see in those cases where patients are being managed for autoimmune diseases or bone marrow transplants or solid organ transplants. More complete deficiency. So the more complete that deficiency is, the more florid the manifestations are, the more accelerated and aggressive the clinical course of disease is, and the less effective your normal management strategy is going to be. And oftentimes patients who have some of these infectious disease processes or other disease processes associated with HIV, AIDS, or immunosuppression, they require long-term treatment as opposed to a standard course of medications. Oral lesions in AIDS patients, we're not seeing as many of these as we used to, and that's on my next slide. I'll talk about that real quick. Oh, maybe not. But it's because the use of antiretroviral therapy, we don't often see oral lesions at the same rate that we used to. But it is important to understand some of these manifestations, because if we're starting to see an increase in opportunistic infections, it could correlate to a deepening or a worsening of their immune suppression. Okay, and that is a sign that used to be used pretty heavily for progression when this wasn't being treated the way it is now. Right, the oral sequelae for HIV infection, again, opportunistic infections that can occur, viral, bacterial, fungal, and then these individuals do have a tendency to develop certain neoplasms at a higher rate. Okay, so I'm going to talk about the viral infections. Well, before I move on, actually, let me just mention one thing quickly. Some patients now, and I'll tell you this anecdotally, but some patients now are being switched from long-term heavy regimens to maybe a lighter or a decreased dosage of their medications. And in those situations where there's a decrease maybe in the dose of the medication that a patient's been using, it may not cause a marked increase in viral load or anything like that, and it may not cause a true drastic drop in the CD4 count for these patients where you're dropping below 200, but it could cause a drop that's significant enough to where a patient may develop opportunistic infections in between. And that's something that does need to at least be correlated to the infectious disease physician or whoever the primary healthcare provider is, that, hey, we are seeing some manifestations of this. So viral infections, the first one being herpes simplex virus, clinical presentation, the initial prodrome symptoms that we see with HSV infection, especially recurrent infection, may not be present in individuals who are immunosuppressed, okay? The vesicles may form early and progress to ulcers very quickly. Typically, the clinical presentation is going to be increased numbers of lesions, larger lesions, and longer duration lesions, okay? This was a very interesting case we had a couple of years ago from across town, and it is this heavy, thick fibrinous membrane here, this fibrinous membrane here, and this is all ulcer. Very little redness around it. It is extremely sore to the patient, and this was biopsied, and it was a very unique histologic finding where the most significant thing was there was virally altered cells that looked like HSV, which was proven on our side with the lab. So we contacted the clinician, said this looks like chronic, HSV infection or HSV infection. We didn't know if it was chronic at the time. And so the patient had been dealing with this for 3-4 months already. The patient was already on an anti-herpes viral medication. And so they decided to talk to the physician who was in charge of the patient's HIV status and management of the medications. And they decided to supplement that medication with an additional medication to help treat this disease process. Well, the patient was presented back to the clinic about a month later. We do see a great degree of resolution of some of the thickened fibrinous areas, but he still had these persistent sort of ulcerations that are a little bit irregular in their appearance. And this was biopsied again. And interestingly enough, the same histologic findings. So this patient, as a function of their immunosuppression or compromised state, had this persistent infection, and their CD4 count was not below 200. It was actually pretty good, no evidence of a viral load, but as a result of that overall effect on the immune system, they're having a really hard time combating this infection. And again, goes to show you that even with 2 supplemented medications, we weren't able to completely beat it back. Oral hairy leukoplakia is a result of Epstein-Barr virus infection, which is another type of human herpes virus. Oftentimes it presents as these white lesions on the lateral tongue, but you can find it on the buccal mucosa. They're described as these shaggy plaque-like areas, almost finger-like or hair-like, not really papillary. I shouldn't say finger-like because they're not really papillary and exophytic. They'll almost look a little more flattened like patches. It can spread, like I mentioned, to involve other sites outside of the lateral borders of the tongue, but more often than not, we find these on the lateral borders of the tongue, as well as on occasion on the dorsal tongue. The disease process waxes and wanes, and it's typically asymptomatic. So it really is a clinical finding that the patient may be more concerned about. And usually whenever you have immune reconstitution, this disease process resolves on its own and doesn't need to be actively treated. So this was a patient that I saw here in the clinic. And the first time I saw him, there were no signs of these lesions in his oral cavity. All he had presented with was persistent lymphadenopathy, a rash that was on his neck and a portion of his torso, and candidiasis in his oral cavity. We treated him for the candidiasis. I asked about the rash. He had said that he had seen a dermatologist who had recommended a cream. And I asked about the lymphadenopathy, and he said he was just going to see his physician because he had been feeling a little ill or under the weather. The next time I saw him was this day, and we saw these white lesions on the lateral surfaces of the tongue. And in this case, he had a few areas on the dorsal surfaces of the tongue as well. And this is oral hairy leukoplakia. So I asked him that, since our last appointment, has anything changed? He said, well, I was diagnosed with HIV. Okay. And he had yet to start his medications. So given his signs, as well as the other symptoms he had mentioned, this really is a progression, of his disease process and further immunosuppression. Okay. So again, some of the oral manifestations that we can see with this disease process. Human papilloma virus infections. There's a little bit of an interesting thing with this, whether this really represents the lack of an immune response or the fact that some of the immune system has been known to kind of incite this virus to go from a latent stage to a more active stage. So there's some speculation that maybe once there's immune reconstitution, this sets off another process that then causes a more florid HPV type infection. In the oral cavity, we can see these as these papillary lesions. Now, these are true papillary lesions, and oftentimes they're multiple and multifocal. And oftentimes you'll also see more unusual HPV subtypes, not the classic 6 and 11 that we see with a lot of the oral lesions that are, again, low risk and not oncogenic. This is a patient in our oral surgery clinic who presented with multiple papillary lesions affecting the palate, the buccal mucosa, and the patient was known to have HIV positivity. And so again, a florid presentation in regards to any of these immunosuppressed states. Bacterial infections, right? So this can present in the oral cavity too, and it's directly due to the immunodeficiency. Oftentimes the causative organisms may be a wider spectrum and more rare types of organisms that typically we wouldn't see in periodontal disease. And the type of periodontal disease that these individuals suffer from is a severe loss of the attachment and pretty rapid bone destruction that's associated with it. Now, this can affect just the gingiva and the periodontium, but then you can actually have progression of these lesions to affect the mucosa, where they end up truly developing a gangrenous type of necrosis or necrosing process into other mucosal tissues. Sometimes an initial presentation may be something like this, which is a linear gingival erythema. There's now thought to be a contribution from candidal organisms in this as well, but it really is just subtle gingival erythema that is right along that free gingival margin. And then oftentimes we get rapid progression to loss of soft tissues as well as underlying hard tissue support. And it can progress to involve larger areas of the mucosa, which becomes even more challenging to treat in these patients. Fungal infections Candida is the biggest one, and that's the one I'm going to talk about. These individuals are at a risk of developing deep fungal infections if they've been in areas that have maybe exposed them to that, or if they become exposed to that. This is often the most common presenting sign in patients who have AIDS, and it used to be that way. Again, we don't see this as often anymore. 90% of patients with AIDS will have oral candidiasis at some point in time. So that's their overall disease process. They will typically present with candidiasis at some point in time or another. Okay. Classic example of pseudomembranous candidiasis, these white areas. And remember, with white lesions, first thing you want to do is try to wipe it. And these are all wipeable white lesions that leave a little bit of a raw underlying red surface. The patient may complain of soreness and discomfort associated with this. So that's that. Neoplastic diseases, I'm going to just focus on one. I do want to make the point that non-Hodgkin lymphoma is the most common malignancy seen in patients who are suffering from HIV and AIDS. But I'm going to focus on Kaposi sarcoma because that has a tendency to be found in the oral cavity with some frequency in this population. Kaposi sarcoma is a result of HHV8 infection, and years ago was the initial manifestation in many AIDS patients, and close to 20 to 30% of that. It is more common in whites and homosexuals than others. Oral lesions often precede the skin lesions, and 50% of the patients who do have skin lesions will have oral manifestations. Any mucosal site really is possible, but it does have a predilection for the hard palate and gingival tissues. Clinically, it can look like various stages because it does go through various stages to a degree. It can be a patch type lesion, and then it can be a little bit more raised, or what we call the plaque stage. And then it can be a fulminant tumor type process, and that is what we call the tumor or nodular phase of this disease process. Typically has this red to purple hue that makes you think it's vascular. And this is a sarcoma in which the cells are differentiating to form blood vessels. So they're differentiating into these endothelial cells, trying to form multiple blood vessels. They don't do a good job of it. And so there's a lot of leaking vessels. So you get a lot of red cell extravasation in the tissue as well, which accounts for the reddish bluish appearance on top of the fact that they're forming a lot of blood vessels. This is a patient with this bilateral sort of purple red hue and swelling on the palate. The clinician had thoughts about lymphoma, which can present with a purple mass type lesion as well. The fact that this was kind of bilateral and somewhat symmetrical was a little unusual. This was biopsied, and histologically it was easy for us. It looked like Kaposi sarcoma. We were able to prove that. And this was a patient who had no history of HIV infection or AIDS, but as a result of the biopsy and the clinician's kind of insight into this, he ended up getting tested and the patient was HIV positive. Here's another case a couple of years ago that we received. The patient had an extraction in the posterior right quadrant in the mandible here, and the site never healed. He was finally referred to an oral surgeon, and at this point, this is a big tumorous mass. The surgeon was concerned for malignancy and did a biopsy, and this was another example of Kaposi sarcoma. Individual had not been diagnosed, but as a result of this, he did end up getting tested and was HIV positive. Here's a case who was seen the ED across town at one of the hospitals here, and this was provided by one of our surgical residents at the institution. Patient knew that he was HIV positive and was not aware of his viral load or CD4 count, had not undergone treatment, but had these multiple red vascular looking lesions, which were biopsy proven as Kaposi sarcoma in this patient. All right, that last category that can result in ulcerations is going to be mucosal reactions to systemic drugs. Okay, there's two basic reactions to systemic drugs. One is the exaggerated but expected response. And the classic example is warfarin as an anticoagulant. And as a result of that anticoagulation, patients have a tendency to bleed readily with minor trauma. And then this idiosyncratic response, which is not typical of the mechanism of that drug. Okay, and so we can get a handful of different types of inflammatory responses, and one of those being aphthous-like ulcerations, okay? So this can result in these ulcerative lesions that affect the oral cavity. In this case, the patient also has some gingival lesions here. And this is one that the patient was on methotrexate. And methotrexate is known to cause oral mucosal ulcers. And this patient had been treated with topical steroids, with systemic steroids, and it just wasn't cutting it. The patient would never get complete resolution. The patient and physician decided to reevaluate, and they found that methotrexate was in this patient's medication list, switched the medications. Patient came back, I think this was within 6 weeks, marked resolution, if not complete resolution of some of the sites that were really long-standing types of ulcerations in this patient. Okay, so going back to that drawing board and looking at and evaluating the patient's medications list is another important part of this. All right, so let's go to our next room. This is our next patient, Miss DeVille. Extraoral intraoral exam that we performed, relatively unremarkable, but the patient does complain of burning in her mouth, okay? So automatically when I say that, everybody's thinking, okay, burning mouth syndrome, right? Burning mouth syndrome, you should understand, is a diagnosis of exclusion. There are a lot of local factors, which we're not talking about today, but a lot of local factors that can result in burning mouth. But there's also a lot of underlying systemic diseases that can result in this as well, okay? And that's really important for us to understand. Vitamin mineral deficiency can result in burning in the absence of other clinical manifestations. So that's one of the first things I do in patients who have these sort of complaints, is to see if there's any sort of deficiency in certain vitamins. Diabetes, underlying systemic disease that can result in burning mouth, amongst other findings. Chronic gastritis in the setting of gastroesophageal reflux disease or peptic ulcer disease can cause this. Thyroid dysfunction, hyperthyroidism, hypothyroidism have both been known to result in burning mouth. And then AIDS is another one that can also result in this sort of neuralgic type presentation in patients who have truly an underlying systemic disease associated with it. So the first one I'm going to talk about is diabetes. We've kind of talked about vitamin minerals and AIDS, so we're going to skip to the ones that we haven't talked about. Remember, certain signs are really pathognomonic for this: the polydipsia, polyuria, polyphagia, increased urination, increased thirst. They're classic things that we discuss with patients who you're suspecting diabetes. Type 1 is a pretty strong correlation with these symptoms. Type 2, it's not as well correlated with those classic symptoms. They may still have them, but it's not always the case. Other signs for type 1 and type 2 diabetes, again, marked irritability, headache, drowsiness, malaise. Xerostomia is another one, which we'll talk about a little bit later. And then with type 2, you can also see some paresthesias, dry, flushed skin, some issues with vision, and a handful of other things that can result in us thinking that the patient may have diabetes, but other clinical manifestations. Fasting blood glucose greater than 126. And again, you look at the A1C. That's very important for patients who are suspecting to have diabetes or who are actually being treated for diabetes, because this is going to be our indicator for how well controlled their disease is, right? And if you have a patient who's a brittle diabetic, it's not well controlled disease, they can present with oral manifestations as a result of their ill-controlled or not properly controlled diabetes. So the complications we can see are a result of the inability to fight infection, poor wound healing, increased vascular disease, and neuropathy. And that neuropathy can result in this oral paresthesia and burning tongue. Okay, so with Miss DeVille, that could very well be the case. She's just not diagnosed as a diabetic. The other signs and symptoms with diabetes are the dry mouth, increased susceptibility to infection, which directly correlates with immune response, poor wound healing, and again, the burning mouth. So there's a patient who has generalized periodontal disease, is a poorly controlled diabetic, was diagnosed, just doesn't take his insulin properly, doesn't watch what he eats, and it results in that periodontal state. Patient also has candidiasis. So again, the pseudomembranous plaques could be a finding that leads you to kind of, hey, figure out what's going on with this individual. What is happening here? Why is this patient seem like they're in an immunodeficient state? Why are normal management styles not working for this patient? There has to be something underlying that's resulting in this, right? Gastroesophageal reflux disease and peptic ulcer disease. Variable symptoms with this. Sometimes it's dyspepsia. So this is just increased burping after eating. So if they have a tendency to belch frequently, they don't necessarily think that that's associated with an underlying, gastroesophageal reflux disease, but it very well could be. Again, it spans the spectrum. Bad breath, respiratory problems, dysphagia, which is pain with eating, nausea, vomiting, those sort of symptoms, as well as GI distress that could be the variable symptoms associated with these disease processes. Another oral finding with gastroesophageal reflux disease or patients who have issues with chronic regurgitation may be this pattern of tooth loss, which is erosion from the gastric acid. So the gastric acid that comes up has a tendency, when you do have that regurgitation, it will hit the back of your maxillary teeth. And that's oftentimes where we see the most erosive pattern, okay? So if you see this sort of sloped erosion on the anterior or the palatal aspects of the mandibular teeth, and sometimes in the posterior mandibular teeth as well, those are the areas that are directly getting contacted with the gastric acid prior to saliva being able to buffer it. Remember, saliva will pool in the floor of the mouth, so we don't often see this sort of acid erosion in that region, but we can see this in this area here. You may actually see some degree of abrasion, not abrasion, but sort of a erosive process or erythema associated with the soft and hard palate as a result of that constant exposure to the acidic contents from the stomach. People who have a tendency to do self-induced vomiting on top of the oral manifestations, look at their hands, okay? They have what's called a Russell sign on occasion, and that could be just a subtle clue to an underlying psychiatric problem that has not been diagnosed, okay? So it's a function of this becoming more calloused as a result of them using their fingers to induce vomiting. And it's just the gag reflex and just chronic trauma of the teeth kind of clenching down in that area. Thyroid dysfunction. So hypothyroidism can also cause burning mouth, but so can hyperthyroidism, okay? And I talk a little bit more about hyperthyroidism here because not only can it cause a burning mouth, but you can also have these kind of tremor-like sensations with your tongue. So these kind of rapid movements that develop. It is 5 to 10 times more common in females with hyperthyroidism in the Western countries. Graves' disease is typically the most common cause, and it's an autoimmune disease process that results in this. One thing that is very important for our patients who present with thyroid disease is to make sure you have their most up-to-date blood work. You want to see how well controlled their disease is, and if there's been any changes in the dosages of their medications. Because if a patient has hyperthyroidism and they don't know it, or it's not properly managed, you are at a risk for a major complication during dental treatment, and that's what we call a thyroid storm. And it is a massive release of thyroid hormone, which will drastically elevate your blood pressure, your heart rate, and your temperature. And it'll climb fairly quickly to about 106 degrees, and cells start to die off between 106 and 113 degrees. And so this can result in a very devastating situation chairside. Classic example of a patient with hyperthyroidism, excuse me. This patient also has this kind of U-shaped goiter in the neck, but the exophthalmos is often or frequently discussed with Graves' disease or hyperthyroidism in patients. All right, the next patient is Mr. John Doe. So moving right along here, he has altered taste, and he's been telling us that he feels kind of parched lately, okay? And you look inside his mouth, and guess what? Man, there really is no saliva pooling in this guy's mouth. You can see this little string-like area. A lot of times when we start to see salivary dysfunction, you'll see an alteration of the viscosity of their saliva as well. It may become a little more stringy or a little bit more mucinous to a degree. And so you can kind of see there's a little bit of saliva here, but we really don't have anything here. When this disease is early, when they have salivary dysfunction, the patients may not truly be aware of it. And the most important finding in those cases is like, oh, well, I do wake up in the middle of the night to have a glass of water, or I keep a glass of water bedside because I get dry throughout the night. Or when I wake up in the morning, it feels like my mouth is really dry. Okay. If you think about it physiologically, humans, being diurnal animals, whenever we go to sleep, physiologically, our salivary glands reduce the rate of flow. Okay. So if a patient does have salivary dysfunction, which is leading to decreased production, more often than not, they're going to feel it most severe throughout the night and the first thing in the morning. Okay, so that's something that's important and can be a little bit of a clue, as well as a little bit of a clinical question to ask these patients when they come in to see you and you suspect they may have dry mouth. All right, there's a handful of diseases that can cause dry mouth. We've talked about diabetes, HIV, numerous medications. And again, I have medications in a lot of these because that's something we do need to focus on. Sarcoidosis is an inflammatory condition which has a tendency to affect the salivary gland tissues and cause destruction and decrease salivary production. And Sjogren syndrome. This is another big one that patients may present with the manifestations of the disease without an underlying diagnosis. So Sjogren syndrome is characterized by dry eyes and dry mouth. It's an autoimmune condition with destruction of the glandular parenchyma. And so as a result of that, you're not producing the typical products that are produced by the lacrimal glands and the salivary glands. It can be primary or it can be secondary to other autoimmune conditions like rheumatoid arthritis, right? Most often we see this in older females, and you'll start to see on occasion some salivary gland involvement, and that involvement will cause enlargement of the salivary glands. That's typically bilateral and more or less symmetrical. The important thing for these patients is they are at an increased risk of developing lymphoma later in life as a function of their disease. This is a patient who had Sjogren's disease and ended up developing a large lymphoma here in the portion of their salivary gland. Okay. Here's another example of this patient, and this is one where we do have salivary gland enlargement. And histologically, this is what we see. It's an immune destruction of our normal salivary gland tissue here. All right. What's important about dry mouth? Well, this is one thing that is often overlooked, and it's a simple fix for us as healthcare providers to address, okay? And that is the dryness. That xerostomia is going to increase the risk of caries, all right? So oftentimes we're so focused on trying to figure out what the primary problem is that we forget what the secondary effects of that disease are. And the increased risk of caries can be fairly devastating for patients where you're not addressing this, okay? Not only does the saliva have a washing effect, but it has minerals that can help remineralize early areas of demineralization. And so this could be a big issue when patients have a loss of their normal salivary flow. So talking to them about using a prescription fluoride toothpaste is very important. Being cognizant of what type of things they have in their diet, acidic things, more sugary drinks is another really important factor for these types of patients. All right, our last patient of the day. Man, we've been through some pretty tough cases today. So this is Mrs. Jane Doe, and intraorally as well as extraorally, she's presenting with these pigmented lesions, okay? And it looks like she has a couple of lesions on her upper lip. Oh my goodness, we look inside her mouth. She has all these macular pigmented lesions in her oral cavity. I'm gonna take a moment just to mention this again, but oftentimes when we see something in a more generalized or diffuse pattern, we have to start at least including systemic diseases in our differential. It could still be a local factor, no question, but you have to at least start considering that could there be an underlying systemic cause for this patient's clinical manifestations, okay? So multiple pigmented lesions, that's what we're dealing with here. And there's a handful of different diseases that can cause this. There's tons that can cause macular pigmented lesions, but more often than not in the oral cavity, we don't see it with that high of a frequency. Addison's disease or adrenal insufficiency is one of those. Peutz-Jeghers is a disease process where these individuals may have perioral as well as anogenital increased pigmented lesions. Oftentimes you'll find this in young children, and they have a tendency to have specific mutations that results in different types of tumors throughout the body. Neurofibromatosis, another syndrome in which these individuals can have these pigmented lesions. Medications. Okay, that's back on the list here. There are a lot of medications that can increase pigmentation. One, through stimulation of melanocytes, or two, through different other mechanisms in regards to, vascular issues or deposition of different sort of pigments within the connective tissue. So Addison's disease is hypoadrenocorticism, and it's chronic adrenocortical insufficiency in the Western world, typically a result of immune destruction. Okay, and it's more of an autoimmune process than it is infection. The oral manifestations, you can get multiple macular lesions in areas where there's just minor trauma. And the mechanism for this is that whenever you're insufficiently making the adrenocortical hormones, your pituitary gland instinctively, because it's a feedback loop, will start making more ACTH to stimulate the adrenal cortex to make these hormones. And the primary molecule to make ACTH is cleaved. And not only will ACTH stimulate melanocytes to produce more melanin, but the other molecules that are cleaved are melanocyte stimulating hormones. Okay, and so they will stimulate the melanocytes to produce more melanin. Okay, it's not going to cause a melanocytic proliferation, but it's going to stimulate the melanocytes to produce more melanin. Okay, one thing I will mention, it's a major complication of dental treatment, is an Addisonian crisis, where the patient does not have the sufficient cortical hormones adrenocortical hormones to fight any sort of stress, and that can result in hypotensive and vascular collapse in these patients. So patients who are either suppressed because of exogenous steroids like prednisone for long duration, or other means of suppression where you've really suppressed the function of the adrenal gland, your body forgets how to make it. It doesn't need to make it anymore, so it doesn't do it. And as a result of that, during periods of stress when you need more, you don't have enough. And that can lead to some major issues in some of these patients. Sex hormones, particularly FSH, LH, estrogen, and progesterone, also stimulate melanocytes in different and varying mechanisms. And in the oral cavity, you can see these in areas where we have some chronic low-grade trauma, like the buccal mucosa, the tongue maybe, as well as other sites. Drug-induced pigmentation, one of the ones I'm going to talk about again is the same pattern here. It's through birth control pills, right? Estrogen content causes increase in LH, and all of these things, estrogen and progesterone both, may play a role in melanogenesis, and so the increased production of melanin with those medications. The pattern of pigmentation kind of mirrors what we see with melasma, which is just this diffuse bronzing of the skin. You can see it in individuals who are pregnant on occasion. So it's areas that are sun exposed, okay, and the sun has a role to play in that as well, kind of like the similar trauma we see in the oral cavity that can stimulate areas of melanin production. Postmenopausal women, again, all surrounding or around the same topic with these hormones. Because we have decreased production of estrogen and progesterone, you have increased FSH and LH, which again can regulate the increased production of melanin. All right, and so you can see it kind of has a similar pattern in the clinical presentation, bronzing of the skin, or these multiple macular lesions. And that is everything I have for you guys today. Just a little bit over. I apologize, but I appreciate you guys walking me through the clinic, or walking with me through the clinic. And hopefully this was a little bit fruitful. Again, I hope the clinical context of this drives home a point in regards to evaluation and management of our patients.
Oh, this was wonderful, Dr. Patel. This, again, just another presentation. I always learn something new from you when I listen to you. Thank you so much. These are just marvelous presentations, Dr. Patel.
I appreciate that. Thank you.
So with that, we'll bid you adieu since no one has any questions. And thank you so much for your time. And we'll look forward to next month's presentation.